Welcome, everyone. My name is Kurt Langlotz, and today I am absolutely delighted to have the pleasure of welcoming Vivian Lee from Verily Life Sciences as our first speaker in this inaugural series. Dr. Lee is an innovative and insightful leader who is not only an international expert in radiology, but also an international leader in healthcare. So I'm really looking forward, as I'm sure all of you are, to hearing her innovative prescriptions for America's healthcare crisis that are detailed in her new book called The Long Fix. Just a word about the Center for Artificial Intelligence in Medicine and Imaging, or the AIMI Center, we call it. We have over 110 affiliated faculty across 20 departments and 3 schools at Stanford, all of whom conduct interdisciplinary machine learning research that optimizes how clinical data are used to promote health. And it's particularly fitting that the AIMI Center and the Stanford Medicine Center for Improvement co-sponsor this session today. AI and informatics and performance improvement and innovation work often go hand in hand as partners to improve patient outcomes and the patient experience. So we're truly happy to be here, looking forward to the presentation. And at this point, I'd like to introduce my colleague, Dr. Lane Donnelly, who is a professor of radiology and pediatrics, chief quality officer, and Christopher G. Dawes Endowed Director of Quality at Lucile Packard Children's Hospital, and co-executive director of the Stanford Medicine Center for Improvement. And he'll be introducing Dr. Lee. So Lane, take it away.
Thank you so much, Kurt. And it's a pleasure to be here and to be co-hosting this event. The Stanford's Medicine Center for Improvement is our group that works on accelerating our ability to improve. And we have focuses on increasing our improvement capacity through educational courses, such as our advanced course in improvement science, as well as creating tools that make it easier for our faculty and affiliates to evaluate their improvement work, publish their improvement work, get grants for their improvement work, as well as groups that work on improving our ability to function as teams and analyze our data, as Kurt has mentioned, as well as look into things like health equity, clinical pathways, and many other things. So again, we are super excited to host this event. And it's my great pleasure to introduce Dr. Vivian Lee. As Kurt has mentioned, she is the president of health platforms at Verily Life Sciences and a senior lecturer at Harvard Medical School. He also mentioned her recent book, The Long Fix, Solving America's Healthcare Crisis with Strategies That Work for Everyone. And we do have some of those books available. So there's a link that you can click on if you would like to have one of those books. It is a limited supply. Before joining Verily, Dr. Lee was the dean of the medical school and CEO of the University of Utah's healthcare. And during her tenure there, she helped lead great improvements in lowering their costs and increasing their quality and increasing their patient experience scores. And all of that combined led to them being the top-ranked institution by Vizient. She is also a member of the National Academy of Medicine, has over 200 peer-reviewed publications, over 20 years of NIH funding. She, education-wise, went to Harvard for her undergraduate and medical training, but also has a PhD in medical engineering from Oxford University, where she was a Rhodes Scholar. And she has been named by Modern Healthcare as one of the 50 most influential clinical executives in 2020, ranking number 11. And also mentioning she is a radiologist and did her radiology residency at Duke University. Welcome, Vivian. Super happy to have you here today.
Well, thanks so much, Lane. It is wonderful to be here, and thank you also, Kurt. It's a real privilege to be your inaugural speaker for this, so thank you. And it's really nice to renew some of these old friendships and connections. Lane and I think, first crossed paths at Duke. So it's wonderful to be able to be with you. And I have added some components of radiology to this presentation just for you. So I was asked to talk today about lessons from the long fix and particularly applications for AI in healthcare. And when I started to think about this, I felt like where I wanted to begin was really in talking about the conundrums, the challenges that we're facing in healthcare, and some of the solutions that we see as being among the most promising, both solutions and approaches to tackling our healthcare challenges. Because I think AI, big data, analytics are simply tools. And the best way in which we can deploy those tools if we really understand what the problems and what the opportunities are. So that's where I'm going to start. And it is tied to this book that has just come out about fixing healthcare. And one of the real reasons why I wanted to write this book was to think about what I think is one of the biggest paradoxes of our times, which is around healthcare in the United States. And this slide is one of many that I think captures that paradox. It shows that the US is really an outlier. We spend 2.5, 3 times as much per person on healthcare than other high-income nations. And at the same time, we're an outlier because we have among the lowest health outcomes. And so in particular here, if we just look at life expectancy, we find that the average baby born today in the US is projected to live 4, 5, or 6 years less than the average baby born in, say, Italy or in Japan or in Israel, for example. And so this is really a very, in my mind, a very shocking and kind of disturbing paradox. And of course, those of us who are in healthcare know that one of the significant factors is that we don't distribute those dollars evenly across our society. And we're really the only high-income nation that does not have universal health care. And in fact, about 13% of our population is uninsured. And I think even more importantly, especially with what's happening with COVID and its economic and health impacts, about 40 to 45% of all Americans are underinsured. And so a lot of the national narrative about how can we ensure that people have access to healthcare, I think is really coming to the fore in our national discourse. And COVID, I don't need to share these kind of data with this group. I do hope that this downward trend is part of the narrative for 2021. But we recognize that it's put an enormous amount of pressure on our healthcare system. There are a few silver linings. I'd say one of them is the fact that we have more young people now who I think admire epidemiologists and public health experts and even physicians and nurses and other clinicians, all of the people who have really been so heroic throughout this entire COVID pandemic. And I just want to say hats off. I know many of you are in these roles who are listening, and I want to thank you for all that you've been doing. What is not such a silver lining, of course, is the impact of COVID on our nation's health and on our economy. And we're familiar with the rising deficit and the new bills that are being proposed, which are, I think, essential. But because healthcare is as much as 18% of the US economy, and this rising deficit has significant implications on what we can afford to spend on healthcare going forward. So here are some data from the Congressional Budget Office put out in the fall. These were projections looking at the Medicare trust fund balances and particularly focusing here on Part A, which is the part that pays hospitals. And originally before COVID, the Part A of Medicare Trust Fund was expected to become insolvent by, say, 2026 or 2027. But with the pandemic, with decreasing employment, decreasing revenues to the government, now it's projected to run out by 2024. So among the many challenges that this new administration and new Congress have to face, one of them is really figuring out how to really pay for healthcare. And I was having a conversation with a friend of mine, Liz Fowler, who has been on the front lines of a lot of healthcare legislation, and she now works at the Commonwealth Fund. And she just said, look, based on her experience, when you're talking about budget cuts, Congress really tends to take a meat axe approach rather than a scalpel. It's going to be, the tendency is going to be across the board cuts, which is not what we need now. And so I think it's ever more imperative, whether you're thinking about it from a healthcare perspective or from a big data and analytics perspective, we need to be thinking, how can we provide more sensible guidance as to how we can address that fundamental paradox that I started with? How can we get better outcomes at lower costs in this country? The good news is that in talking with all of my colleagues in healthcare, and many of you, I'm sure on this call, is that we do have a reasonably shared understanding of what we need to do. And for the book, for example, I asked over 100 healthcare leaders the same question: what's the one thing you would do to change in the US healthcare system if you had that magic wand? And the majority said paying the way in which we pay for care, that we should be paying for health instead of having this fee-for-service model, which just simply pays for more and more procedures to be done to us. And this sentiment is actually, I think, bipartisan, believe it or not. This is viewed, this move to value was as much championed by Secretary Leavitt under President Bush as it was through, of course, the Affordable Care Act and even the Trump administration. So there is a shared understanding about this. I think the challenge is that it's just not that easy. If only it were as easy as this slide, move from fee-for-service to value-based care, we're done. The fact is that because the fee-for-service model is so deeply entrenched in our healthcare system and in our business model, in the way we compensate physicians and in the way in which we track our success, just so deeply entrenched, it's a very, very difficult evolution that we have to undergo. That said, it's not impossible. And in fact, the country, I think, has been making a lot of progress. And I wanted to start with a story that I came across when I was doing some research. And this is the story about ChenMed. And I think it's a great example of moving from volume to value and how it's working even today. So I'm going to read a short segment from my book. This is from chapter 2, An Apple a Day Keeps the Patient Away. And I'm talking with Chris Chen. He's a physician. He's the CEO of ChenMed. And he's talking about his dad, who actually founded this medical group practice. So, and it starts with a quote, because he's talking about how other people talk about his dad. So in this quote, he says, "Go see that crazy Chinese doctor who takes care of all the poor Cubans." Chris Chen grins as he tells me how people used to rave about his father's clinic in Miami. His father had started as a typical primary care doctor in private practice. He was paid fee for service, which meant the more patients he saw, the more he earned. Then in South Florida in the early 1990s, a few insurance companies started experimenting with new ways to pay doctors. Instead of fee for service, they gave them a fixed amount per patient per year, a fixed amount. If a patient needed expensive imaging, costly drugs, or long hospitalizations that added up to more than that amount, it was the doctor's problem. Chris's dad, the doctor, and mom, the office manager, experimented in this new model. They welcomed referrals, but other doctors sent them only their frailest and poorest patients, the ones they knew would be grossly unprofitable under this new way of paying. That's how Chris's parents began with 250 of the sickest people in Miami, people who would have been almost impossible to keep well at any facility at any price. It looked as if the Chens had signed up for a financial suicide mission. Because resources were scarce and their patients' needs were many, the Chens decided to focus on primary care and prevention. Their fragile, elderly patients had to be seen frequently by doctors. Once they got sick, it would be too late. So they set up monthly visits, even if there was nothing wrong. Getting to the clinic would be tough for many of them, so the Chens provided free door-to-door transportation. They worked out that averting the cost of just one ambulance ride and hospital stay could pay for a year of shuttle service. They opened a pharmacy in the clinic so their patients could conveniently, cheaply, and reliably fill prescriptions. Somehow, that crazy Chinese doctor and his wife not only provided outstanding care for their patients, including many who often didn't have enough to cover copays or deductibles, but they also managed to make them healthier. They reduced hospitalizations, and even more amazingly, they broke even financially. Out of desperation, the Chens invented a better way to do healthcare. Now, this model that I describe here, where the medical groups are paid a fixed amount of money to keep these patients healthy, has actually evolved to become the Medicare Advantage program. And Medicare Advantage is actually the fastest growing program. It's now about 40% of all Medicare patients are actually in Medicare Advantage. And what we're seeing pretty consistently in the literature is that these programs actually enable physicians to practice medicine the way they want to practice it. And by investing more upfront in primary care, they can reduce hospitalizations and overall reduce the costs of care. So I think it's a great example of this move from volume to value. And also we found that during COVID, this program has actually proved even more robust because these medical groups knew that they could rely on that income from Medicare. So it's not only driving more value, but also creating more resilience. So that's one example of how this better model of healthcare can really work across this country. And in the rest of the book, I talk about what this better model means for patients and their families and communities, what it means not only for ambulatory care, but also hospitals and other components of the delivery system. For other industries like the pharmaceutical industry, what if we actually thought about paying for our medications based on their cost effectiveness or their impact on our health? And I'm looking at Kurt with that comment, and thinking about big data as well, that industry. And then a focus on employers and other payers. Employers, as you know, pay for healthcare for about half of all Americans. And so there's I'll talk, if I have time at the end, a little bit about that. And then finally, I kind of wrap it all up in some policy recommendations. So for the rest of this presentation, what I wanted to do was to highlight 3 themes, how we can think about big data, analytics, AI, in helping hospitals and clinicians deliver value. And then I have a case study in diagnostic imaging, thinking about how we help patients co-produce their own health. And then finally, if I have time, a little bit on payers at the end. I'm not sure if I'll have time or not, but we'll try. So one of the big challenges in moving our system, as I mentioned, is it's not easy to move our whole businesses. These are, we're talking about billions, hundreds of billions of dollars, and really pivoting them up really 180 degrees. And I think one of the key lessons that I learned throughout my work, especially when we were in Utah, was just how important it is to use data in order to engage people in this algorithm for change, in changing the way in which we practice and in changing what we value in healthcare and how we do it. And so this is an algorithm for change really taken from business school, sort of Change 101. But the underlying sentiment of it is that we really need to think about the psychology of the people that we're working with. And so I love this quote from Socrates: the secret of change is to focus all of your energy, not on fighting the old, but on building the new. And specifically with that in mind, I want to talk about a case study and really focus on these 3 components of the algorithm for change: data, using data to engage faculty, staff, trainees, and to empower them to change. And particularly focusing on the clinical part of transformation, moving from volume to value. This was a slide from the old Utah days where, of course, this is not a real equation, but it's sort of metaphorical, saying we really wanted to focus on quality, on patient experience, and on cost of care. And in particular for this example, I'm going to talk about the quality piece, which I think has been one of the real challenges in our healthcare system. And to do that, I like to talk about Amory Codman, who I don't know how many of you have heard of Amory Codman. He was a physician around the turn of the last century, grew up in Boston, trained in the Harvard system, and his name is associated with there are a lot of eponyms like Codman's bursa, Codman's triangle, Codman's shoulder, and so on. He came of age at a time when surgeons were doing many firsts. And what was really unusual about Amory Codman was that he believed in data. And I think essentially was one of the first champions of a learning healthcare system. So in his pocket, he carried these little index cards, one for each patient, that he called the end results cards. And each one of them described a patient that he'd seen, what he thought the diagnosis was, what he found in the operating room if he took them to the OR, what happened afterwards, and then 1-year follow-up. And what was controversial about Amory Codman was that he believed that everyone should be judged on their end results, that these data should be made public and that patients should choose which doctors to see based on their end results. And remember, this is in the early 1910, 1915. This was quite early. And he also believed, in a very controversial way, that all faculty should be appointed at Harvard Medical School and promoted based on their end results data. In fact, he believed that he should be made the Surgeon in Chief at Mass General based on his superior end results. And it might not surprise you to hear that the rest of his colleagues didn't agree with that sentiment. And in fact, rather than becoming the Surgeon in Chief, he was actually forced to leave and step down from his role at Harvard Medical School. And he set up a separate hospital called the End Results Hospital. And there, after 5 years, he actually did publish the results of every single one of the 300 some patients that they took care of in that hospital, with every complication noted. So there's some very positive lessons about Codman in terms of creating a learning health system, but there are also some negative lessons about how not to engage physicians in change. And his approach, which was on the more negative, kind of more critical and really leaning towards humiliation side, was not so successful. In contrast, I think that there are some very positive lessons that we can learn about behavioral psychology, about engaging physicians. So I'll just spend one moment mentioning this book by Daniel Pink called Drive. I don't know how many of you have read this book. He pulls together a lot of work in the psychology literature, and really what he's talking about, he's not focused on healthcare. His lessons apply to all kinds of work, or even if you're managing teenagers, there's some lessons even there. But his fundamental point is that to really engage people, if you can tap into their intrinsic motivation, you're more likely to get more engagement and better solutions. And for physicians, especially trying to tackle difficult problems like managing care, I think this is a very valuable lesson. And so those components of intrinsic motivation are a shared sense of purpose, which I think we all have in medicine. Making sure that there's a strong sense of autonomy, that the physicians feel like they have autonomy in making decisions about how to drive change, what is quality, what are better outcomes. And then that sense of satisfaction at mastering the goals that we set out together. And so an example of this I pull out is in some of the work that we did when I was at the University of Utah on quality, when we were facing a lot of criticism from our physician staff about the national quality metrics that they were being held accountable to. And so we said to, in this case, the orthopedic surgeons, we said, okay, you tell us what you think perfect care would look like. You tell us how you think we ought to be measuring quality. And so what I'm showing you here is their perfect care tracker. This was for total hip and total knee replacements. And some of these are familiar to those of you who are in this space as ones that were required to report on, like PSIs or patient safety indicators or readmissions. These were all left in there because we still did need to get paid. But they added a couple additional measures, including admission to OTSS, which was the Orthopedic Trauma Surgery Service. So they said, we don't want our patients overflowing into general surgery. We know that they receive better care and have better outcomes with dedicated teams. And also, we want our patients to have early mobility, to get up and out of bed on the day of surgery. It's evidence-based. Both of these points are evidence-based points. People who get up and out of bed on the day of their joint replacements do better. And it turns out we were not achieving that element of perfect care for everyone, because our patients who were coming from the operating room at the end of the day were arriving on the floor after the physical therapist had already gone home. So that was easy for us to correct. Once we were measuring it, once we detected it, we shifted some of the physical therapists to a later shift. And we were able to show meaningful improvement in outcomes, reducing length of stay and reducing the cost of care. This was actually published in JAMA. So it was, I think, a great example of engaging physicians in this process and allowing them that autonomy and that mastery. And I think others apply the same principles in what they're doing. So Geisinger calls, they don't call it perfect care, they call it proven care, but it's a very similar idea, having their physicians really contribute to defining that. Mayo puts their folks on a pedestal. They're not just doctors, they're experts. So you can ask the Mayo experts about how they recommend providing care. These are all part of that same mindset of how do we engage physicians and then use those data to provide the right kinds of guidance to continue that path towards higher value. And once we create that learning health system mindset, I will say that there are tremendous opportunities to continue down that path, whether the AI is applied to our data and analytics tools around costs and care pathways, or even, for example, on the imaging side in the operating room, using AI-driven surgical platforms to enhance intraoperative learning, real-time intraoperative learning, for example. When you put this together, the opportunity to engage physicians in this transformation can be very meaningful for the hospital or the medical group. And I share some of the results that we had at Utah. What I'm showing you here, let's say first in the orange numbers was our quality rankings with Vizient, or formerly University Health System Consortium. And University of Utah was able to stay in the top 10, or has been in the top 10 actually for the last decade. In the bar graphs, it's the margin. So by improving outcomes, improving quality of care, reducing length of stay and complications, because of the payment being based on DRGs, because of our payment model, many of those savings actually fell to our bottom line. So in gray, the national average of non-for-profit hospitals around 2 to 3%. I inherited a system that was around 4% in 2011, and we were able to more than double the margin, in part due to these kinds of initiatives. So I think the lessons of some of this transformation from volume to value is that you can do good and do well. A case study that I pulled out specifically because as I was looking and reading about the center, I saw some familiar faces from the imaging days. And imaging is one of those spaces where we really benefited a lot from the old days of fee-for-service. And so I thought it was a good case study for moving from fee-for-service to value. So let me see if I can do this relatively briefly. Back at the turn of the millennium, there were a lot of reflections on the overall impact of different innovations. And many of us in radiology were very proud that so many of the things that we did were at the top of those lists, including here, MRI and CT scanning coming out at the top of that survey of the top 100 medical innovations. But at the same time, we were very mindful of the criticisms that we were getting. And here's a cartoon saying, first, we're going to run some tests to help pay off the machine. So yes, we were having a lot of impact, but we also knew that we were having an impact on cost of care. And, you know, at its peak, it's pretty remarkable to realize that imaging was making up 10, 11, 13% of total Medicare reimbursements. Oh, I have this as a slide, so let me see if I can. And then, ta-da, there was a significant drop that has led many groups to kind of really revisit, I think, the role of radiology in healthcare. And I'd say that for the most part, the reaction has been not necessarily to focus on driving value, but just to increase the volume even more. So with decreased reimbursements to try to make up for it with volume. And here was a study that Ashish Jha and his team published, I think a couple of years ago now, that just showed that the number of MRIs and the number of CTs in the US just continued to increase. So as I said, making up for that decrease in reimbursement with volume. But instead, of course, there are a lot of other ways to drive value. And there's been some really good work looking at just, well, could we actually reduce the cost of imaging by improving our own efficiency so that we could pass on those savings to our payers? So if we could reduce what it costs us to produce images, maybe we could share those savings with the payers. And So this led to some cost accounting projects. My old friend Bernie Birnbaum from NYU days did this work at Penn. And then Yoshimi Anzai did a study just a couple of years ago at Utah, looking at what it actually cost us to perform our imaging studies, not what we're going to charge or bill, but what it actually costs us, kind of a COGS in business terms. And it's surprising how little we really understood about this. So here's an example of how she did the process mapping. This is Yoshimi's paper from Academic Radiology. And she looked at abdominal pelvic CTs coming from the ER, outpatient and inpatient, and just did a little workflow for what happens to them along this process, and then counted up the various cost components, the cost of the nurse, the cost of the IV, and so on. And if we were in a smaller group, I've asked for a show of hands, kind of to guess, just how much do you think the costs of a CT come from the expense related to the technology? Because usually we think about it, well, the CT machine is expensive, so that's why it's so costly. And, so I would normally ask you, but I can't ask you in this venue. So I will just show you, but mentally, make a guess. I'm just curious, what do you think? How much do you think of our CT costs is from the technology? Well, it turns out very little. It turns out that 80% of what it costs us, again, this is not what we're billing, but what it just costs us to produce a CT study, 80% is labor. Half of it is the physician and half of it are other staff. And actually only 6% has to do with the technology. And this opens up a lot of opportunities for us to figure out, well, how can we reduce those labor costs? Do we really need physicians running around trying to find the old history or find the old exams or figure out the creatinine, for example? And of course, there are many other ways that we can think about how radiologists and other imagers, people who do diagnostic imaging, can improve value for the system, whether it's providing earlier diagnosis, reducing misdiagnoses, more timely management. A big area that a lot of people have focused on, and Stanford has been a leader, has been in reducing pharmacy costs. If we can identify with, molecular imaging or MRI, for example, that some new biologics are more effective and we can, or not effective early on, we can actually significantly reduce costs, for example. So there are many opportunities here, and I just encourage the radiology or other imaging community to really think about how we can extract more value from the work that we do and think about us as participating in that broader journey towards value. So that was probably the biggest chunk of this presentation, was thinking about health systems. But I do want to talk about engaging people and patients. And in this regard, I actually am calling out another distinguished Stanford faculty member who was, I think, one of the earliest to really talk about this notion of co-production. And so I'm going to talk about co-producing health and the role of digital health in co-producing health to advance value. So this was a publication by Victor Fuchs, who's an economist at Stanford now, and published in the 1960s. And he was really talking about the overall shift from moving from a manufacturing economy to a service economy. And this idea that in a manufacturing economy, there's more of a tendency to think of what's happening in the manufacturing plant is producing a good, and then it's sort of thrown over the fence to the consumer to use. And there's really not a whole lot of collaboration or shared, they don't build value together, it's kind of separate. But in a service economy, there's much more of this idea of co-producing value. And so some examples are, for example, if we're thinking about education, we don't just rely on our schools and university. We, help our kids with homework, or we're doing the PTA. We don't expect, waste management to come into our household and do it. We actually do our bit. We have smoke alarms and fire extinguishers, for example. So we co-produce fire safety, we co-produce education. And the Bataldens actually wrote this really excellent paper, which I think I cited here at the bottom, on how this really applies to healthcare, that we really should be thinking about healthcare or health as something that we as clinicians co-produce with our patients. And I'd like to just put forward the notion that digital health is a way to even further accelerate that and really enable the co-production of health between patients and the healthcare delivery system. And when we talk about co-production, a lot of what we're recognizing is that the vast majority of health is really dependent on how people are behaving outside the four walls of the clinics and hospitals. Of course, it's what they're eating and drinking and exercising and the environment in which they're living, as well as the social factors that they're exposed to. And so I think that this recognition has just been fairly amplified during the COVID pandemic. There are a number of companies in this space, way more than I could fit on a slide. But I want to highlight that I think the lessons from, say, the Livangas, the Omadas, the Verdas, and the Onduos are, I think, really, really valuable. And ordinarily, again, if I were in a room with you, I would be asking for you to show hands. How many of you have tried a digital health app? How many of you have tried a wellness app or even a fitness app? Because I think we're just at the very beginning of what's going to be a really exciting period of innovation in this space. So I highlight one example that I know well, and I have disclosures in bold here. I show this as an example of a digital health solution that has been, I think, really transformative in diabetes. And again, very similar to the other products that are on the market. It starts with a continuous glucose monitor, which enables people to measure their blood sugars continuously 24/7 on their phone or on their app without pricking their fingers multiple times a day. By taking pictures of your meals and snacks, patients or individuals with diabetes can make a visual association between what they're eating and how it's impacting their blood sugars. And, you know, they don't need AI necessarily to realize that this breakfast muffin wasn't maybe the best choice for them. But in some cases, the AI algorithms are incredibly helpful for identifying patterns that are very personalized, that really vary a lot from patient to patient. Soy milk might be better for Kurt, while skim milk might be better for Lane, for example. A lot of those recommendations come out through the AI algorithms that we're using. And then, of course, the human touch, video conferencing, chatting, and those insights being produced and revealed for the clinicians as well as part of this process. And we're seeing consistently, regardless really of the company or the manufacturer, consistently significant improvements in hemoglobin A1C, in blood sugar control with those kinds of technologies that really, as I say, enable people to co-produce their own health. And for those of you who, I just want to throw out that this idea of co-production extends in all kinds of domains. And I'm also a real champion of co-producing education. And I have a highlight example here of a program of innovation that was created at the School of Medicine at the University of Utah that came straight out of a couple of engineering students' minds. They were undergraduates in engineering. They came to me when I was the dean and said, hey, we want to create an alternative to our senior research project. We don't necessarily want to work in a lab or on a quality improvement project. We want to innovate and create new digital solutions. And so they put together a proposal for how to do that in partnership with the business school and the engineering school. And we created a whole new path and a whole new option for our students who wanted to move it down that innovation path. And so I think it's a great example of co-producing education. As part of this work in thinking about our patients with diabetes that we work with in my company and others, of course, we've been thinking a lot about the many other complications and how we can prevent those. And so here's an example of using artificial intelligence, not in radiology images, but in retinal images. This was actually a space that I've been interested in since I was a teenager. My parents actually worked in this space of diabetic retinopathy. And of course, now the AI algorithms are able to they've really significantly improved and enable the detection of retinal abnormalities in people with diabetes and other visual disorders that are comparable, if not superior, to groups of ophthalmologists. And I think this offers enormous opportunities for not only in the US, but even more importantly, across the world where we have inadequate access to the experts, the ophthalmologists who are needed here. Now, one of the reasons why I really like showing diabetic retinal images is because of this paper that came out following some of that AI work looking at diabetic retinopathy, and just simply said, well, what else can we extract from these fundus images? So this was some work that was published maybe 3 years ago now, where it started actually with an intern at Google asking the question of, can we predict gender from retinal images? Can we predict blood pressure from retinal images, recognizing that the blood vessels in the back of the eye could be representative of the cardiovascular system more generally. And so they published, I think, a really interesting article in Nature Biomedical Engineering showing reasonably high predictive value in terms of looking at cardiovascular mortality, hypertension from retinal images. And of course that I have to bring it back to some of the imaging work earlier to say, beyond thinking about imaging as driving value in healthcare systems, just the images themselves probably have a lot more value. And I know many people at Stanford are working on this, but thinking about all the ICU plain films that I've read throughout my life, there's a lot more information hiding in there than we're able to extract value from right now. So I know we want to leave some time for questions, so I'm just going to be very brief about this very last point and say that I think there's an enormous opportunity for us to be engaging payers, especially employers, in driving value. So to finish out from clinicians to patients to now payers, how do we think about data and analytics and AI even to enable them to really move the dial on value? And here I finished with a story because I think that this story is actually really, really revealing about a group of employers in Seattle. And this is a story that is told to me by Bob Mecklenburg, who was chief of medicine at Virginia Mason Medical Center. Virginia Mason is in Seattle and was the health system for some major employers. So I'll try to see if I can do this briefly. So let me just read you a short segment of this. So in December 2004, Bob Mecklenburg received a visit that pretty much ruined his Christmas break. Mecklenburg was chief of medicine at Virginia Mason Medical Center. His hospital was paid to provide health care to employees of 4 of Seattle's biggest companies and employers: Costco, Nordstrom, Kings County, and Starbucks. In his office that day was the medical director of Aetna, the third-party administrator for each of the 4 self-insured employers. He told Mecklenburg that the care provided by his hospital was too expensive, and that unless something changed, they would dump Virginia Mason. Mecklenburg, who is responsible for hundreds of millions of dollars in his department's annual budget, most of which was clinical revenue from caring for patients, had a startling realization. I'd never come face to face with people who paid my salary. I thought Virginia Mason paid, but it was these employers. He wanted to understand the problem better, so he asked the 4 HR heads what was driving their climbing healthcare costs and lost employee productivity. Back pain, headaches seemed common, they said, but beyond that, they weren't sure. So I go on to describe how he collected all of their claims data. And as he called it, his Christmas project that year was to go through just sheets and sheets of spreadsheet data and really put together information and insights for these employers that they had never seen before. And as a result of doing that, he actually found a way to really engage these employers in thinking about healthcare as what he called a supply chain problem, meaning that a clinic that failed to keep an employee from getting sick and missing work was like a chip manufacturer who sent a poor quality part to Intel. You know, if employees are homesick, Nordstrom can't sell clothes and Costco can't restock shelves. And so what he did with these 4 employers was to work with them to draw up these performance specs, just like they would with any other supplier. And there were 5 of them. 1, give us what works and skip the rest. They only wanted to pay for evidence-based medicine. They wanted 100% customer satisfaction. Guess who that was? That was Nordstrom. They wanted same-day care. You know, the Starbucks guy said, you can't imagine ordering a skinny, tall, white latte and saying, oh, come back in 2 weeks, you know. Number 4, rapid return to function, something that we've never really been accountable for, but of course is the most important to employers. And then the 5th is predictable and consistent prices for buyer and seller. And so by doing this and by creating the tools and the analytics to enable Virginia Mason to meet these specifications, Virginia Mason became the center of excellence that Walmart and Lowe's and everybody else started flying their employees to. And again, that was a data and insight and analytics challenge that wasn't really that difficult, but was actually transformative to the employer journey. So with that, I think I'll just wrap my remarks to a close and say that there is a lot of work for us to do, and I look forward to a really good discussion. So thank you very much.
Thank you so much, Dr. Lee. And we have a number of ways that questions can come in. So let me start off with a question while we're getting the other questions. You obviously have a lot of experience in working in improvement science, and obviously the work that you accomplished at the University of Utah, and also a background in artificial intelligence. And obviously the future of how we improve things, as Kurt mentioned at the beginning, is some intersection between those 2 things. And what are your thoughts on, have you seen ideal models about how those 2 different groups of people interact or are positioned to attack the many problems in healthcare?
Well, I think the key is to just recognize that, you know, I think fundamentally it's like everything. What you really need to understand is what is the problem we're trying to solve, and then what's the right set of tools at our disposal in order to solve those problems. AI isn't really the solution for everything, of course. And so it's really most important to have, in my experience, to have really people who really understand the clinical problems, if that's our focus today, the clinical problems, and then the quantitative people who really, the data and quantitative people who really can speak the same language and can pick and choose from their toolkits what's the most important. For us at Verily, our teams actually are comprised of these subject matter experts, engineers, and product managers. But then I would say the secret sauce are our user experience researchers and user experience design folks, the people who really understand the psychology of the folks that we're trying to work with and who are supposed to be using these various tools. Because as I think all of you know, just presenting people with the data and the analytics alone isn't always enough to really move them and get them to change or to do something differently. So I think it's all of those groups working very closely together.
Thank you. One of the questions submitted is around privacy challenges in adopting AI in healthcare, and what are your thoughts on how that can be optimally managed?
Yeah, so that's a really important question. I think that overall, in the technology sector as a whole, one of the most important things for everyone in this industry to think about is to really earn and maintain the public trust. And because we know that there's so much potential benefit. Like I was just talking about these digital health solutions, we're just at the very beginning. And we know that if we do it right, we can really improve access to care. We can reduce the cost of care. We can just improve health, but we have to maintain the public trust. And a big piece of that is ensuring that people feel comfortable with sharing their information, and they feel like they're getting value out of sharing their information, and that their own data is going to be protected. So in our company, we've been very mindful of that when we partner with other institutions, and if there's going to be any sharing of data where we're, for example, doing some analytics for them, we are very transparent about what's going to happen. We have public announcements, we have discussions with folks about it, and we really, I think it's really important to be as transparent as possible. Why are you collecting information and what are you going to use it for? And making sure that people understand that and also understand the potential benefit to them from that engagement. I think that that's really, really, really important.
Thank you. Here's another question that talks about one of the issues with digital technology is the lack of proper validation, rendering safety being unclear. And how are you guys addressing those types of issues?
Oh, I think that's really important. So we've been involved with the FDA pulled together a roundtable, a group of companies really to start this discussion, I think a couple of years ago, to say, how can we ensure that digital health actually generates the evidence and is held to the right level of review and validation. And it's a challenge for the FDA because the pace at which software changes is so much faster than the pace at which other products that they review, what they're accustomed to reviewing. So we've been involved in that early on, and I think that's actually really essential. It's also really important. I want to say that I think digital health solutions also offer an opportunity for us to pivot from the standard fee-for-service model of healthcare to more of a value-based care. And what I mean by that is, I also think it's important for these digital tech companies not to just recapitulate the whole fee-for-service thing. Every time you video or every time you click with something, you charge and you charge and you charge and you charge. But instead, really, the digital health companies need to be held to a higher standard of delivering value. And we're trying to do that actually in Onduo. We have some contracts where we are really only paid for better health outcomes. So if the patient population has a better glycemic control or better blood pressure, or they've had their kidneys checked according to recommendations, for example, that's when we get paid. So I think there's some real opportunities in the digital space to ensure that we are held to the scientific bar as well as to a higher value or business-based model as well.
Thanks. Maybe we have time for one more. This question asks, what are your thoughts on how healthcare systems can quantitatively measure quality and value?
How can health systems quantitatively measure?
Mm-hmm.
Okay, so that's actually one of my favorite questions. So value, I'd say, I'd like to just divide that into two pieces. I think on the outcomes part, we still have a lot of work to be done in terms of thinking about how do we measure health. We've, of course, focused a lot on process measures in the hospital. There's been a lot of pushback from a lot of physicians and others on those process measures. And that's why I showed you the perfect care idea of saying, well, okay, if you don't like these process measures, are there other process measures that you like? But really what we need to do is to take a step back and say, well, how can we overall improve these measures so that they not only reflect what the physicians think, but include patient-reported outcomes, of course, and more outcomes measures that reflect the underlying conditions of individuals and the underlying variations. So more risk adjustment, more accurate risk adjustment, for example. On the other side, there's the cost piece, and something that we didn't have time to talk about today, but that has been a real passion of mine for a long time, and I do write about it in the book, is the opportunity to measure the cost of care. So I showed one example in radiology. Some of the work that we did in Utah was really measuring what it cost us to do everything. What did it cost us to perform an appendectomy, to do a corneal, to do corneal surgery, or just take care of a patient with pneumonia. And for the first time, we as physicians seeing those costs and really understanding, understanding how it is that our decision could actually influence overall cost was completely eye-opening and really, really transformative. So I think there's a lot that can be done now to improve measurement and to make those data more transparent to those of us who are being held accountable to it. It's not fair to judge us when we don't have the chance to measure ourselves and to see how we're performing. That's actually something we've been doing a lot in the company. It won't surprise you that at Verily, that's a big part of what we're working on.
Great. Thank you, Dr. Lee, both for your excellent presentation today, for your leadership in the field of medicine in general. It was great to have you here. Nice to see you again. And all of us here at Stanford, thank you for your time today.
Well, thank you, Lane. And I'm sorry, I see all these questions. So if you want to reach out to me, I have a website, Vivian Lee MD, or I have an email for these purposes called thelongfix@gmail.com. So feel free to email me your questions and I'm happy to answer you. Yeah, so sorry we ran out of time. Thank you.
Thank you so much.